Hello, everyone, and welcome to today's Tuesday topic. Today's topic is getting you and your learners in the zone with J Morse, our Assistant Dean of Experiential Learning and Innovation and an Associate Clinical Professor of Nursing. This event is brought to you by the CNHP Simulation Committee. And so without further ado, let me throw it over to you, Kate, to get us started, and welcome. Thanks for joining us.
Fabulous. Thank you. So let me just switch over to slides and including my colleagues, Jen Carroll and Jen Pareca, who are our simulation colleagues, and inviting them as co-faculty to chime in at any point in time because they've been working with SIMZONES. They've been applying it to some simulation designs, and I think they have lots to offer. They'll also be helping us when we get to our point of doing breakout rooms. So we'll send you out to do a little work, and then you'll come back and we'll talk about that. So what we hope to achieve today is describing and defining SIMZONES, and we'll talk about the original article that was published in 2017, and we're working on a subsequent articles, but we'll talk about how we are thinking and looking about SIMZONES and why are we using it for curricular design, and then what's different in the academic context versus the professional context, which is where it was originally written. You all will design a little learning chain through zone 0 and 2. So that gets you just a start of thinking through how do we know your learners are ready to be in the phase of learning that you're designing. And then I want to talk about some of the implications for faculty development for Zone 4. And Zone 4 in our context is really when our learners are out in their clinical practice, whatever that may be. So for undergraduate nursing students, it's predominantly hospital-based or community care. Our nurse practitioner students in their clinical spaces, our therapeutic students may be in outpatient clinics, or they may be, under supervision doing psychological therapy. So zone 4 for us is when they're out in their clinical practice. So why do I think we should be doing this? So let me just step aside and say, if you've not read the original article, and it's on the last slide here as a reference. So the SIMZONES is a curricular design tool that integrates with really good instructional design. So it sort of overlays those two. And it was designed by Chris Rusin and Peter Weinstock when they were both at Boston Children's Hospital running the simulation center on the professional side. And what they learned, just like we've learned in the academic side, is that oftentimes we've well-intendedly designed simulation experiences for our learners, and they've gotten in there and we've been surprised, and they've been surprised that they're not ready to be there. Either they've not practiced the skill recently, so they've had substantial skill decay, or they've never done the skill and they're not ready to be there. So they end up having a very negative learning experience, and we've sort of missed the opportunity and perhaps damaged the teaching-learning relationship. So Chris and Peter were trying to figure out, how do we know and why do we care that people are ready to be in the learning space? And they were very interested in people being ready for clinical practice. So they were very interested in, how do we create this chain of learning so we don't have people really upset in simulations when they're trying to teach ECMO and they've never, ever used the equipment that goes with it. So they don't even begin to learn the ECMO principles because they're stuck on the equipment and they're not ready to be in that learning space. So realize that we need to we have to identify what the skills are related to what we're trying to achieve. So, and we need to spend time deliberately building those skills, which I'm going to show you some slides. That's going to be zone 0 and zone 1, where we as faculty are coaching and teaching, but they're only focused on the building of the skills before they get into those learning spaces where they're applying the skills in some context, but not so much context that it's too much cognitive load, and we'll talk a little bit about that, where there's continuous development of teams and there's multidiscipline and there's great complexity in the simulations. And that all is to get them ready to get into practice. So this readiness for practice, when we think about it from academia, we want them to have the requisite skills. We want them to be able to apply those skills to the appropriate clinical situations. And then we want them to be able to do it in more complex areas and interprofessional communication. And all that is going to get them ready to be in the clinical world and hopefully to be competent in their appropriate discipline. So without this readiness chain, we end up missing bits and pieces and putting them in the space that they're not ready to be in. And then, we're surprised they're not doing well. Or if it's an assessment piece, then they're falling short of the assessment mark, but really we put them in the wrong space and we were assessing the wrong thing. So it allows us to think about, are our learners ready to be in the zone of learning that we're developing, and be really thoughtful about, well, what are the skills that they need to know before they come into applying this in a complex simulation where there's multiple moving parts and there's family members and they have to deal with the patient and they have to call the physician or they have to interact with another team member. There's a lot of skills that go into that. And when was the last time they practiced those skills? So it helps us think about it, and we hope that it helps you think about it. And then it also is that link that goes across the curriculum. And for our academic students, they're constantly moving back and forth, right? Because they might go to clinical and be ready to be in clinical, but then something new comes up that they've never done in clinical. And now they got to come back to zone 0 and start all over again, because now they have a new skill, or they learn, they move from one specialty course to the other. And now they are starting with a new skill set. So now they're back at the beginning, and that's okay. But they're continually moving back and forth between these. And we need to be sure they're ready to be in those spaces. So this is the original SIMZONES. And please, sing out if you have any questions, or if I say anything that makes no sense at all, or Jen, chime in anytime. So the original SIMZONES was, again, on the professional side. So Zone 0 was designed as being auto feedback. So it's something that faculty and educators have designed, but learners are engaging individually and they're getting automatic feedback. So like using a mannequin, and they're practicing their CPR and they're getting feedback on the depth and rate of it. They're in a VR simulation and they're getting feedback about their communication skills and they're interacting. Or, Jen's escape room, and they would be going through the escape room, seeing videos, responding, picking the best responses, getting automatic feedback. Yes, that's correct, or no, and here's why. And they're learning. So it's in the nose. If you think about Miller's pyramid, they're getting the material, they're knowing the material. Then they're ready to come to zone 1. And for us in the nursing side of the world, that's foundational skills. For the PAs, that's foundational skills. It's health assessment. It's starting their diagnostic reasoning. It might be some basic procedures. And Megan, for you guys, it's your basic physical exam for PT. And there may be particular things that are foundational. And we as faculty are working there, and we are coaching, and we are pausing, we're correcting, we are teaching, but we're not necessarily exploring. We're observing, we're advocating, and then we're coaching. I saw you come in and introduce yourself to the patient. And then I saw, without asking permission, that you immediately took off their gown. I'm thinking sometimes that can be shocking to people. So next time you come in, ask permission. So I'm not interested necessarily in their frame, but I'm saying what I see, and then I'm coaching on it. So this foundational instruction, it needs to be deliberate and consistent for all of us. So if we're all teaching the skill, we should be teaching the skill exactly the same way. And that's part of deliberate practice. and helping our students engage in some peer feedback using the same deliberate practice model is only going to make them stronger. So zone 0 and zone 1 foundational instruction, like on Miller's pyramid, is knows and knows how. And if we're like matching it up with Benner, then we're definitely we're very much in the novice land. Then zone 2 simulations is where they take what they learned in zone 0 and zone 1, and now they put it in the acute situational instruction. So you can see down here that on this second, on the clinical signal and noise in zone 0 and zone 1, there is nothing else going on. You got a student and the content and the skill, and there's no other distractors. So they are not having to do this on a real person. They're doing it on a mannequin. So, they're listening to hearts and lungs on the SAMI mannequins. They're practicing on perhaps each other, but they're not practicing on a standardized patient yet. So their signal, which is the clinical cues, is very high. And the noise, which we'll talk about cognitive load in a little bit, is as low as we can get it, because they don't have the cognitive load to have that all meshed together yet. And as we move to zone 2, you can have a little bit of cognitive load, but not as much as we do as we get down to zone 3 and zone 4, which is real life. So acute situational instruction is simulation, but it's scaffolded simulation. It could be pause and discuss for us. It could be a faculty coach in the room, but we're not saying to them, so great, you're going to see a patient today and it's going to be a code. Or we don't even tell them it's going to be a code. And off they go and they're completely overwhelmed. They're not ready to be in that zone 3 where it's team behavior and greater complexity yet, because they've not practiced in the acute situational instruction. So the intent of this curricular build is that you're having increased complexity, increased noise, decreased signal as people get more experience. Does that make sense to people? So for us in academia, the zone 3, think of our interprofessional sims, our disaster sims. I would say, that Drexel deliveries is sort of, as Jen and I say, like a 2.75. And you'll notice that there's no bright lines between the zones. There's dots, which is intendedly so because there is a little smush on both directions. And as we said, people are going to move back and forth depending on if they're learning a new skill. But we can't transfer things and go, oh, well, we're just going to, they've already had a zone 3, so we're just going to do zone 3 again. And yet this time we're talking about delivering bad news. We've got to go back to the beginning. We have to, get them ready to be in foundational instruction. So they need the didactic and to have some familiarity with auto feedback. And then they have to get coaching. And then they have to have, role play, low risk, low cognitive load. Then they go into the simulation. Because it's super hard. And I'll say to you, we still hear from students that their perception is they're, in the past were thrown in. We don't want people to feel like they're thrown in. We want them to be challenged, but not overwhelmed. So this original design from Chris and Peter was real life. And zone 4 was real teams debriefing after events in real clinical time, solving clinical problems. Whether they had a bad resuscitation or a great resuscitation or an ECMO or a labor and delivery crisis, but it's real teams in real life. And we've been trying to figure out in the academic setting, we think, and you guys can help us think this through because we keep testing it out on people and see if it makes sense, is that zone 0 is essentially the same. Zone 1 is foundational instruction with coaching and they're practicing their skills. Zone 2 is situation. They're applying those skills in situations. Zone 3 is those complex events, resuscitations, rapid response calls, interprofessional, Drexel deliveries, disaster sims, Megan, your students, I think when they came in and got the patient out of bed that was post-cardiac surgery, like that for them was probably pretty close to a zone 3 because it was pretty complex for them. And then zone 4 is their clinical rotation. So whatever that appropriate clinical rotation is for them. So the learner goals is the same thing. It's knows how, shows, does, performs. And from the faculty standpoint, we are coaching, teacher, instructor, coach. And then towards the end, we are facilitator, guiding, caretaker of the team, and co-developer of knowledge. So we, definitely our stance as instructors change. And that's not to mean that you can't be in, zone 1 teaching skills. And you're like, wow, I've told this student 3 times, when you introduce yourself to someone, don't stand over them, sit down. And we've said it 3 times and you're still standing up. So I'm thinking there's something getting in your way because you're a smart person. And I think we've been very clear, but maybe I've not. So let's check in and explore what's going on for you so that we can help you sort of get beyond this. So it's not to say that you can't use those explore tools, conversational tools, but for the most part, you are coaching in a deliberate way for students. Not just telling, right? Because that's a unidirectional activity, but teaching and having some exchange back and forth. So it's the same thing, simplicity, low noise, high signal. And then as the learning in context gets higher and you're going up the zones, you're having more lifelike complexity, more noise. So when our, like for PA, we're just working with Ryan Clancy to design a delivering bad news case where his learners will meet a patient that's in a bed, an embedded participant, and they're going to have to deliver a bad news diagnosis. So we have to backtrack and make sure that they have practiced and had experience with what model of are they going to use to deliver the bad news. They've practiced those skills and developed their own authentic voice. They've gone back and forth with that. And maybe they have an event where they do some role play. So it's situational, but yet still low risk. And then they go in to see the real life patient, which is pretty high risk for a student. But we can't just put them in the sim and not have done that coaching and got them to practice. Because sending them here's the cognitive aid, here's the tool, read this article, they're still in the knows, but they don't know how. And we need to help them to know how. And I think that's the piece we've sometimes missed. And Jen, you guys have been designing events now with faculty. So can you give a couple of examples of how you've sort of created this chain for people?
Sorry, I wouldn't unmute. So one of the challenges that I'm finding is that to do this, it requires a little bit more time because I think that the challenge with, incorporating sim is always time. I have this much time and we need to get, 100 students through. And how do we do this? And so, what I'm finding is that to kind of structure it this way in a linear way where you have groups that are small enough that it does require a little bit more time. But it's really interesting to dig into, all right, based on these objectives, how do we backtrack and how do we kind of build this? So it kind of makes you think about this in a way larger curricular perspective, which is, an opportune time for nursing anyway, with the essentials and all of that. So,
yeah. And serendipitously, yesterday we were doing Drexel deliveries and they had the didactic knowledge earlier in the day because they had class. Then they came and Jen did the instructions and the coaching around 2 particular skills, IM injections and reading fetal heart tone strips. And then they went in the sim and did it. with a faculty coach in the room. Jen was in one room, Maureen was in the other. So they weren't by themselves. So it was, zone 2 for them because they weren't left to sort of have what in the past hasn't always been a productive struggle. And in the debriefing, what we heard from them was like, when I left class, I wasn't really sure how to interpret the rhythms or what they meant. And then we got more teaching, and then we got to see it with a person in the bed in active labor. And now I'm going to remember this. Like, it was the perfect chain of the power of doing it. And yes, I agree that, it takes a little bit more creative planning, and we have to make it scalable for you all with large groups. And the educational payoff is, I think, significant. And as we sort of think about threading simulation through a curriculum in a meaningful way, so, we're not thinking about it course by course, but yet connecting it throughout and making sure that we are attending to, oh, wow, we're doing this really great delivering bad news skill, but nowhere in the curriculum do we have conversations about the model of delivering bad news. And we didn't spend any time practicing that. So that we need to fit into either class time or onto the sim time. And all of this, it doesn't matter where we're teaching, is underpinned by good judgment, which is holding students to high standards and in high regard. So high regard is the basic assumption that we believe everybody's intelligent, capable, and cares about what they're doing and wants to improve. And, we're holding them to the standard because the basic assumption doesn't imply we don't have hard, good feedback conversations with them. It means that we do because we believe they're capable of doing more. And our behaviors as faculty is that we're really transparent with what we're thinking. We're staying away from guess what I'm thinking questions like, what do you think you could have done differently? Anything else? And we're being transparent with our thinking. And the conversational tool with that is preview, advocacy, inquiry, which you can use anywhere, doesn't live in debriefing. But what we want to do is, as we help and plan Sims with you guys, is to ask the questions now, like, how do you know, or how do we know that your learners are ready to be in there? And then that way you can sort of track your curriculum and go, oh, yes, this is where this material lives. And this is where we practiced it 2 weeks ago in zone 1 in their fundamental skills lab. And now they're coming and they're having a low risk situational instruction, and they're getting to apply it in a clinical situation. So we're still trying to figure this out in our writing team of how does this fit into academia, and how do we help people sort of make it accessible for them. So why do we care about this? Well, we care about this because I think it talks a lot to cognitive load for our learners. And unintendedly, I think sometimes we have put them in simulation where their cognitive load is way too high. And then in hindsight, it's really no surprise that they were a little overwhelmed. So when we think about cognitive load and simulation design, we think about intrinsic, extrinsic, and germane cognitive load. And this is all about getting stuff out of our working memory into our long-term memory so that we can then retrieve it and you're going to remember it. And I love the working memory work. And it's so funny because depending on who you reference, you can have like 5 to 7 items in your working memory, and others say 2 to 3. And I think we all agree our working memory after COVID and all the things that we had in our brains, I feel like mine's not as good as it used to be. Or it could be that I'm 3 years older. So it's important because we've got to really think carefully about the extraneous cognitive load that we add in simulation. So that can be thought of as noise and distraction and tasks that aren't particularly germane to the content that occupy the working memory, and therefore learners aren't going to be able to get this laid down in their long-term memory. So extraneous load are things like, well, gosh, wouldn't it be really fun if we add a difficult family member? Well, sure. but where's the learning objective? Is this in the service of learning, or is this, wow, that would be fun? Or we put them in where there's loud monitor alarms, there's an IV pump, there's a blood pressure pump, there's a pulse oximeter, and they're really focused on how to manage all that. And they're not paying attention to how to manage the patient. We take away all that extraneous cognitive load, they can talk to the patient and do a great history and figure out what's wrong with them, because they're not ready there. And then it's extrinsic or intrinsic cognitive load is the difficulty of the problem. So how hard is the material? And what do we do with this as educators is we try and link it and scaffold it onto past knowledge. And, Jen Carroll did a beautiful job of this in her Patho course, because at the beginning of every class, we pulled forward their old knowledge and then tried to link it to what we were learning today so that they could have some way of anchoring it. Otherwise, they have another whole level of knowledge that exists in isolation. And for them, we're trying to help them. And simulation is, I think, a really great place to do this. We're trying to help them create mental models of how to put these clinical pictures together in their specialty. So cognitive load is really important in sim design. And you can see by the sim zones that with signal and noise in zone 0, zone 1, and mostly zone 2, that our extraneous cognitive load should be as low as we can make it. Then in zone 3, yeah, it's fair game because they have all those skills and they've already practiced in the situational context and they're ready, and they have enough ability to move on and be able to survive in that noise or high extraneous cognitive load environment. So I find this super helpful, and I sort of love the cup because you have a limited space. So if your extraneous load is too high, your cognitive load or your germane load is going to go down, and students are not going to leave with the learning that we hoped that they did, and that you've spent a lot of time deeply thinking about, but how we delivered it wasn't the best way. So I think SIMZONES helps me to think about it, like based on what zone are we in, then we need to be really thoughtful about our extraneous load. Like, do we really need to be in an ICU with all these bells and whistles? Because they've not really done it on a, semi-stable person yet without all of those. So we need to get that down first, and then let's put them in with someone who's super sick, or someone who's super upset, or a family member that is over the top in terms of not being willing to listen, and it's very difficult to manage for them. So I think this links nicely in, and this is the signal to noise. And our colleagues at the Hong Kong Jockey Club, which is, I know sounds a little odd, but they are the people in Hong Kong that built the simulation center in Hong Kong. And they did a lovely job with making the poster pretty. But when we think about signal and noise, the signal is the cognitive cue and the noise is the extraneous cognitive load. So for novice learners, we need a really high signal. They have one thing wrong with them. It walks like a duck. It talks like a duck. I'm having chest pain. It's central sternal. It goes down into my left arm. I'm, 60 years old. I'm diabetic. My brother died when he was 45. No other health problems. Like, it's classic textbook, really loud clinical noise, and your noise is very low. For experienced learners, you can make that signal a little lower. So those learners can now see competing diagnoses where it's, oh, okay, they just got off a plane. Had a history of cancer. It could be a PE. They also have lung disease. They also have cardiac disease. So very, more competing things to tease out. So it's fair game with more experienced learners to have a lower signal, a more muddy signal for them to sort out and add in some noise. But very novice learners should have very high signal and very low noise. So we also think about that in the design of simulation. So we might, you might come in and want to do a lot of things, and we'd say, well, how about we do this first, and then you can have a second sim that once they get their feet underneath them, they can have a little bit more noise. And that goes with the sim zones, moving from zone 2 to zone 3. So what does this mean to us as educators, and why should you care about this? I think we should care about it because I think we shift our frame of thinking, and serendipitously, we had a nursing faculty meeting today talking about what are the opportunities or problems that we want to solve. Well, when we think about what are our educational problems that we want to solve in your specialty or in your clinical course, or that you identify as a gap in your clinical training in your specialty, then we're thinking of SIM as a way to solve that problem. And then we need to think about, all right, do we have all the dots lined up, and do we know they're ready to be in this SIM? So we're really leveraging the time that you've put into developing a really great case by getting the learners being able to embrace the desirable difficulty in that case because they're prepared by having foundational skills, and they've had a zone 2 where they've had some really great practice and feedback in a lower cognitive load situation. This means, and many of you already have what I hope are really great relationships with Jen and I, and, sitting down and hashing out and writing cases and sending them back and forth and sort of figuring out what's the best thing that we can do, because our job is to solve problems for you. What's the best thing we can do to serve your students? And that requires all of us to have a good relationship and to be able to employ instructional design along with simulation. And resisting the lure of, what if we did this? I just saw this great case, and I was in clinical practice, and we should do this SIM. Great. What are the learning objectives? No, it's a really great SIM for you. Yes. But we need to, where would it fit in your curriculum, and what are we serving in the learning? So really being vigorously staunch to holding to, okay, we need some learning objectives, and then let's develop the case around it, not backwards, which is we have some case and now we're going to sort of, take a shoehorn and fit some learning objectives into it, which is how we all started, by the way, is we, pulled things from our clinical lives and simulated them. And then we're like, what were we trying to achieve there? So that helps us, I think, be very rigorous. So before we sort of go through some examples that I came up with, and I want to hear, what other examples you can think of for different zones. And then we're going to do a worked example, and you're going to do a little work. Questions, comments? Clear as mud. I'm not seeing anything in the chat. So Kathleen, I love your question about zone 2. So let's hold on to that, because these are perfect examples. So let's think about adding an example, and what would that mean? So we were trying to think of zone 0, and we've talked a lot about this in SIM of virtual reality. Of course, bubbles immediately to your mind because that's your own journey, and you're getting automatic feedback. Virtual escape rooms, I think, would work very well, because Jen, you've had a couple, you've done them where they did them in teams, but you could easily do that individually and be getting automated feedback. Skill practice with automated feedback. We do have the capacity, like if they were, for example, starting IVs, we do have the capacity to, they can have a flash, and automated feedback of obviously they got in the vein would be an option. And I know MedMath on the nursing side is a problem looking for an opportunity to how can we best meet our learners, but that could be them doing individual problems and in an app and getting automated feedback before they come to get coaching, so they sort of know what their challenges are. VSIMs, which are virtual sims that are designed, and they are designed commercially, is an option. Go React is also a program that allows, very similar, Fran, to the original practice, XYZ, then practice, then what the variations on a theme of the name, where there are videos and their learners are individually responding, and then they're getting expert feedback. So the work has gone in ahead of time. So other individual things that people could do where they're getting automated feedback, that faculty involvement is on the design side, but not in giving feedback during the process. Are you guys doing anything else that would fall under here, or any other ideas on it?
I'm starting to play around with Kaltura pathways, but that, and to see if depending on the response, then they automatically get feedback, but I'm in the very early stages of storyboarding that out. So that would fall in zone 0, right?
Yeah. And these are things that could be assignments in your course. It could be pre-work to coming to the simulation lab, whether they're seeing a patient in the standardized patient lab, or they're doing fully immersive sim, or before they come to their fundamental skills lab. So zone 1, the who, it's usually individuals. We're not coaching teams in zone 1 yet. And they're learning how to do a skill, but it's not just psychomotor skills. They're learning how to have conversational skills, how to build rapport, how to deliver bad news, how to listen, how to do a history, how to ask appropriate questions in, a history of targeted history versus a comprehensive history. So all of those we should be teaching with the same standardization as we do when we teach how to do psychomotor skills. So to me, we think about this in our fundamental labs. Health assessment for HSCI, the health sciences, health assessment for our PA students, health assessment for our undergraduate nursing students. And it could be a refresh of skills prior to zone 2. So it may be something they learned a while ago, and now they're coming back, and we're going to do, half an hour of a skill that we're going to have them apply in zone 2. When we know that they've been taught it, they've had some feedback, but maybe they have skill decay and they have not had a whole lot of opportunity to do it. So we're going to get a refresh of them before they go into their zone 2 step. And we've had very good feedback on students in doing that. They're very grateful because it might be a year since they've done the skill, the original skill, depending on what their clinical availability was. And we as faculty, we're the coaches, and we're using deliberate practice feedback models. And then zone 2 could be partial team leaders. So they're applying zone 1 learning in a clinical context. So Kathleen, thinking about this in the online environment and thinking about some of the things that we did in COVID, in which I think would be zone 2, for example, is on the couples and family therapy students. We had trained standardized patients who were a triad, so 2 parents and a young teenager, and they were in therapy. So the faculty is there, so it's scaffolded, and it was with pause and discuss. So 2 students would, start the therapy session, and then there would be a pause, and there would be coaching for the student who was doing the therapy, and everyone else are the observers, and then they would trade out. So all the observers know everything that happened. And then they would step in and pick up the thread, and they would interact with the standardized family, and then they would get coaching, and they could stop themselves at any time when they were stuck, or the faculty could stop them when they were going down a pathway that maybe wasn't being productive. Does that meet sort of what you were thinking of, or what were you thinking of for zone 2 in the online? Yes, Diane, that absolutely requires synchronous sessions. So this is you as the faculty are actively engaged in coaching and teaching. So zone 0 would be, work that you've designed it, but you're not there. But zone 2, you are with your learners in that clinical context in some way. And we can, oftentimes our standardized patients are the educators as well. So they could be the ones that are pausing the students and giving them feedback and then letting them pick it up after a little redo. So we often think of, rapid cycle deliberate practice with psychomotor skills and all the research that was done on how to run, pediatric resuscitations. And it also works with conversational strategies, right? So if you start off and you don't introduce yourself and your standard embedded actor says, all right, Kate, I'm going to pause you. You didn't introduce yourself. That is a really important thing to do because that starts our rapport. So I'm going to roll you back and let you restart again. So I restart again. This time I introduce myself and they let me continue until I make a mistake and then I go. And Diane, so yes, this is absolutely does not have to be in the clinical context. So we do this around conversational strategies, conflict resolution, difficult conversations, negotiations. So absolutely. You're simulating that content. So it's still simulation, but it's not clinically focused simulation. So yes, it is, in my mind, fully applicable, and we've done it. And I think it's very powerful for learners to do it. And we do it for feedback, we do it for listening. And I think those are all important skills for all of us, no matter where we are. So these were some of the examples that we thought of zone 2, where we have the faculty coach in the room, where we might be doing pausing and discussing. We might be doing rapid cycle deliberate practice and whatever skill we want them to obtain. But it's scaffolded. They're not in there by themselves, sort of, trying to get to the end. There is a lifeline, and we're coaching and pausing, and we're still in the role of coaching and teaching, and we still have a fairly low cognitive load for them. Once they've done this, then let's put them in a zone 3, where they're working maybe in a team, where they're working, if they're doing therapy, maybe now they're doing group therapy instead of individual therapy, or they're working with a complex patient, PT, that has other medical problems, not just a physical problem, and everything else is healthy. So we're trying to get them ready to work as a team and interact in their appropriate roles as they go out to be a profession. Could be fully immersive simulations. And Diane, thinking the non-clinical, the fully immersive sims that we've done for this is you have to run a meeting. Here's the context. Here, everybody has, frames that are not obvious to you, and there are relationships, and we spend time, creating, and you guys have to solve a problem, and that's the simulation. Here's the problem you got to solve. Like we did one not that long ago. Of course, it's sim focused, but the problem was, your center has been awarded a gift of $2 million, and everybody has very interesting ideas about where that should be spent. And you have to moderate that meeting, understand everybody else's frames, negotiate, manage, and those sims are great. And they're
Kate, so what I currently do is they're paired with another student, and they each get their role in a scenario, and they don't prep. They can prep all they want, but they don't talk about it beforehand, and they have to record their conversation. So one might be a chief nurse, one might be a chief information officer, something like that, and they each have their own agenda, and they have 3 minutes to try to use persuasive techniques and things like that. And it's okay if they get to a stalemate. It's not trying to get to solve the problem. They're trying to apply the skills. So I'm trying to think of if to get to a zone 2, I'd have to be there when they're doing it. And that's the problem is that this is online. People live in California, and most of them live on the East Coast. But what are their times? and then my time in order to do that. That's pretty labor intensive.
Yeah. So we've, I've done it where, yes, you have to, somebody's going to get gypped on the time zone issue of, trying to find. So I used to do them at different times. So not the same person was disadvantaged all the time, but you might, be in and out of breakout rooms while they're practicing. How do you negotiate? Like what language do you use when someone's saying something in your brain? In your internal dialogue is very different than your external dialogue, all those things that help people have really good conversations. So it's a problem that can be solved, and it's figuring out, we can help you figure out what would that look like. We can try some practice runs and see what that would look like for you.
Right. And the other thing that could be done is those students could record their breakout room, and then you could critique it later on, even though you're hovering from room to room, but then you could look at the whole thing. That might be one way of it, but it isn't real time, so that's a piece
but they're still
right now they record it and they post the recording, and then I give them feedback and their peers give them feedback. So
and I think Diane, you're helping us think through like the nuances of academic and how the zones work, because it's not going to be exactly the same. So, does feedback have to be immediate? I think if you're looking at somebody else's Flipgrid or somebody else's video and you're giving feedback, you're still giving deliberate feedback. So that feedback loop, then you just sort of have to figure out, like, did they listen to the feedback? Did they?
Right. I mean, I would love to have them then get the feedback and then redo it.
Yes,
but there's not time. You've got so much packed in that the time to do it is the hard part, to get that redo, because it's that refreshen and reiteration where they really learn and they can apply what they learned. Looking at these different zones, they look at this and they learn something here, and then they learn and they build upon that. And sometimes with time-wise, it's really hard for them to be able to do that, get the feedback, and then have to get a chance to redo it again and get feedback again.
This would be really interesting if it was going over a couple of quarters. We're doing the curricular revision, where they would have the opportunity to refresh, as Kate was talking about, what they learned in the last sim, which was last term, and now they're going to, apply it, the same understanding, what they gained, but to a new ramped up thing. I mean, might be worth pursuing, because we all have that time issue.
Yeah, and that just like made the light bulb go off, rather than looking at this is the course on this and this is the course on this.
The whole
this is the whole curriculum initially. Like it's just using zone 0. Then we move to zone 1 in the next course. Then we move to zone, and it's got all 3 of those, concepts, or 9 of the concepts in it. So that would be totally flipping education on its head.
Well, and that's
in their leadership core, Diane.
Right. Yeah.
Imagine that using the 3 courses.
Yeah.
And then maybe zone 3 for them is when we have a sim day for them that we do virtually, and that includes having these complex meetings and pulling everything together. So we're building. But I love Jen's comment of curricular anchors using the sim zones. And you're right. It doesn't have to be lockstep 1, 2, 3, 4, and maybe you're going back and forth, and it's across the curriculum, because 4 is like real life. So their clinical life or their new role, and getting to competency doesn't happen in a course. It happens across the whole curriculum. Yeah. Love it. Great conversation. So I was just trying to figure out a way, because it's not a linear process. So, this is my attempt to make it not linear, which I'm not sure is very good, but understanding that our didactic, and then we build on the knowledge all the way to get to people being able to be in their clinic, whatever their new role is, whether it's clinical or non-clinical, but their new professional role, and be competent in their new professional role. And yes, Darren, thank you. So let's do this. So these are some of the questions that I think we've been asking ourselves and asking you as we start to meet with you and think about incorporating SIMZONES into how we plan SIMS is how do we know our learners are ready to be where we're trying to put them? And how do we know if our students are ready for practice before they graduate is like a bigger question of pondering competency for every one of our specialties. And how do we know if they're ready to progress? And maybe if they're stuck in zone 2, they're not ready to progress. And we collectively need to design a way to have another path for them to help them get over that hump, so that we're not just adding on cognitive load for them and they're stuck way back in a prior course. And then how do we incorporate teams? Because we're not currently doing a good job with our team learning, and we have an interdisciplinary college. So we're making the argument, and Megan, I know we're trying to figure out a way to get undergrad students with your PT students. So there's a conversation at the bedside. We have an apartment that can be conversations in the community space. We have, briefing rooms where we can have professional conversations, or we can live stream those to online students. So I think creativity is always a plus. So let me just pause that piece because I want to just pull up and have you guys think about coming up with a worksheet of figuring out what are you trying to achieve. And maybe, as Diane said, you're expanding it across the curriculum and figuring out where you're putting each zone, and thinking about that in your curricular designs. So how can we help you incorporate this piece? And this is sort of my first attempt to help us collectively when we think about using SIMZONES to design and solve a problem in your curriculum, whether they're not getting clinical experience or they're, you want to animate a part of your curriculum, who are the learners, and then creating these learning chains so that we're thinking about, well, where is their zone 1 learning and didactic, and where did they get to practice zone 1? And now they're ready to be in zone 2. Do we need to do a refresh before they come? Because it's been 2 quarters. So I'd love to get your feedback and any questions. We're not going to have time to do breakouts of how this would help you think through designing simulations online, in person, and integrating it into your curriculum.
How many learning objectives do you think are too many or not enough for each of the zones when designing your activities?
Sure. So really good question, Jen. So the general rule of thumb in simulation is that for 5 minutes of activity, so let's say on the zone 2, zone 3, where you're immersing people in a sim of some sort, that's 1 learning objective. So a 15-minute sim should have no more than 3 learning objectives. And oftentimes people come with like 6, 10 plus. That's 4 cases. That's great. We can do all this, but you can't do it all at once. So I think we tend to have too many because we tend to try and put too much in everything because we feel that curricular pressure. And then we end up with way too much cognitive load for our learners and we shoot ourselves in the foot. So I would say I live by the 5-minute rule when designing zone 2s and zone 3s. And less is frequently more. Because one learning experience is not going to solve all your clinical or professional.
But when you get to zone 4, you're trying to interweave, or interleave a lot of different layers. Mm-hmm. So you've got that communication piece with the clinical skill, with the clinical reasoning, and all of that comes together. So there are a lot of objectives when you get to zone 4,
So I
right?
would
Because you've
still
got more
pair them.
noise.
Yeah, so I'd still be careful and pare them down. So zone 4 is real clinical practice. So they're out, and your students may be out on a leadership, and they may have, so if they have like, this is my day, these are my objectives for today versus these are my overarching objectives for the entire clinical experience.
Okay.
Is a lot more time, but it's the same thing is that, they're demonstrating, right? So in zone 4, they're actually doing, and in zone 3, they're showing how, and in zone 1 and 2, they know how. So in zone 4, they're doing.
So zone 4 is actual, like a practicum.
Exactly.
Whereas zone 3 would be the simulation in the academic environment.
Exactly.
Got
Yeah.
it. Okay, that's where I was confused. Okay.
And my thinking is like zone 3 simulations are like, Megan, if we did an interprofessional with the nursing students and the PT students, so we're getting, we have that increased complexity of how do you work in a team? How do you talk to one another in a team? And the handoff sims that Jen and Jen are designing and running for the undergrad students, that's sort of hovering between the two because they have to pick up the phone and call and talk to a simulated provider and give handoff of a patient and have a conversation. And that's pretty close to zone 3 because they're now working in a team. There's a higher cognitive load, there's a lot involved in that for them on the learner side. And again, it's not a bright line. And I think, we always want everything to be linear and we're going to smush. And what if I'm in my clinical practice and I'm not doing well, Megan, and you're getting feedback from your preceptor and you're like, okay, Kate, you got, come on back to the practice lab and we're going to practice, we're going to go back to zone 1 and help you with those foundational skills in order to get you back to zone 4. So I feel like in the academic, students are going to move back and forth a lot. But it's super helpful for me to think about if I'm teaching and I'm in zone 4, I'm exploring, I'm facilitating, I'm trying to, help them with big picture and integrate knowledge. But if they're struggling with a skill, then I'm going to switch and I'm going to be the coach. So I find it helpful to think about where am I supposed to be doing to help the learner the most that I can at this moment. So do you think this structure of having conversations with, us with you, in the team approach to figure out, okay, so you did all these activities in zone 0, you did all these activities in zone 1. So yeah, we're definitely in zone 2. What are the learning objectives? Now, how are we going to design that sim for you? And I think we have to play around, but other thoughts or questions, and these are really good. It's really good thinking. Super helpful.
I would just want to add that some of the things we don't know until we actually do the sim, like we might design it in a way where we're like, the students are going to be so supported and this is going to be great. And then the most important thing afterwards, I think, is gathering data from the students and recognizing, whether we hit the mark or, there were things that we didn't consider, and, constant revision of these sims to make sure that they're supported and that they're learning with what we're doing and how we're designing it.
Yeah, that's so important because what we think and what the impact is right. Yeah. It seems really easy and straightforward to us, and it may be super hard for them, and we're surprised. And I'm trying to be more deliberate and think when we're doing these things, like what if the students get stuck in this case? How are we going to help them get unstuck? Like, what's the lifeline? Is one of us going to walk in and go, hey, I was just walking by, heard you guys needed help. But what do we, and sometimes we do that, right? We have the attending or we have the charge nurse or we're the whatever. But yeah, Jen, really important to have that close did it land in the zone that we thought it is, or is it scaled wrong? Did we get it wrong? And then we just adjust. So I know we're at time. These are really good questions and super helpful thinking, and love, reach out to any one of us, Jen or myself, and talk through, how can I do it in my course? How can I do it in my curriculum? We've got 3 brains to be your partner and figure out, ways that we can integrate this into all of our curriculums to help our students.
Thanks, Kate. I
Very
appreciate
helpful.
it.
Yeah. Thank you.
Mhm.
Thanks, Kate.
Thanks, everybody. This was a really fascinating discussion. And thank you, Kate, for your work and for your whole team. And
Quick question before we hop off, Darren. Hey,
Yeah.
the schematic slide, or 2 slides, I'm not sure if they were 2 slides that you showed earlier in the presentation, do they live somewhere that if someone wanted to look at them to kind of get an understanding of it, that they could download or view?
I'm happy to send you a link to the PowerPoints, because I imagine on the handouts, it's probably, those slides are little and it's hard to see. So I'm happy to send you a link to the PowerPoints.
All right, sure.
But no, they don't live anywhere beside my OneDrive. And Kathleen, sure. Yeah.
All right. Thank you.
Okay.
Thank you.
Thanks, everybody.
Thank
See
you.
see you next time.